conclude our program, I'd like to wish a warm welcome to Dr. Khalil. He's a transplant surgeon at Cleveland Clinic, so he'll be giving us an update on liver transplant. Thank you very much.
Thank you very much for inviting me. I'm one of the transplant surgeons at Cleveland Clinic. This was an excellent talk, and I'm glad I heard this. Very good talk. There's a lot of interesting stuff. I took a little different perspective on this talk. I tried to summarize. There was a lot of interesting topics, so I just, instead of educating everyone, I focused on educating myself. So I chose topics of interest, and I kind of summarized what exists and what we know about them to kind of get a conclusive idea of where these topics stand. So I divided my talk into three different aspects of emerging topics. One was like what are we talking about expanding indications for transplant. Other was about what are we doing about expanding donor pool in those patients, and there is a new hot topic of transplantation that is utilizing more and more of minimally invasive surgery. So expanding indications, I'll talk about briefly about a couple of topics. One would be obesity, that what are we doing about obesity in the peri-transplant and transplant period, and then the second would be transplant oncology. So we all know that, you guys know more than any of us, this is the risk of MASH LD and MASH recurrence after transplant remains extremely high, and with MASH-related diseases or obesity-related diseases becoming the most common indication for transplant, the risk reduction becomes a very important concern here. GLPs and new weight loss medication playing a bigger role, but with decompensated cirrhosis, they have at least some limitation at this point. So the bariatric surgery is of great interest. So the question becomes, is bariatric surgery going to play a bigger role in transplant patients with obesity? So this is a study from a Mayo Clinic. They have their 10-year experience of patients who underwent sleeve gastrectomy with transplantation or transplantation alone. So as you can see, there is some very clear benefits in the long term. One would be like sustained weight loss. They have decreased incidence of diabetes prevalence and lower incidence of allograft steatosis, which is one of very significant finding. The graft, overall graft and patient survival was very similar, but when they looked at the graft fibrosis score, there was much lower graft fibrosis score in patients who underwent combined treatment. So I think in future, obviously medical weight loss is going to play a bigger role, but I think bariatric surgery is going to see a more extended utilization in a peri-transplant in a transplant phase. With regards to transplant oncology, HCC is very nicely covered. I'm going to talk about three relatively uncommon indications for transplant that are increasingly becoming more and more common, would be colorectal and different variations of cholangiocarcinoma. So colorectal cancer is is the third most common cancer, very deadly, very high risk for recurrence, and 50% of these patients have liver metastasis with very poor survival if they do not get any definitive intent treatment. So initial experimentation with transplantation for colorectal was started by one of the pioneers of transplant, by Dr. Starzl in the 1980s. Very poor outcomes, and then eventually it was decided that it is not worthwhile pursuing this route. This came back to interest from our group in Oslo, and the reason they explored this option was because they just had too many grafts. They just wanted to see if they give it to people with high-risk disease is going to be worthwhile. And they conducted two studies, SICA-1 and SICA-2. As you can see, that there's very clear advantages of the Nordic 7, which is a chemotherapy alone, versus SICA group of overall survival in these patients. So that rejuvenated the interest in transplantation, but again, the risk of recurrence and it remained high, and it never gained mainstream traction unless the trial that was published last year by Transplant Trial is a French trial, 18 center, randomized into chemotherapy or non-chemotherapy. Very well received trial, very well done trial. So if you look at the data, so the 5-year overall survival with liver transplant plus chemotherapy was substantially higher than the chemotherapy alone, 57%. And they still have very high risk of recurrence, but despite having high risk of recurrence, the survival substantially improved in the transplant group. So I think what we're going to look at in the upcoming days is going to be better disease selection to improve this 57% survival, which is lower than any other malignancy for transplantation. But I think with better disease selection, which includes you utilizing some of these tumor markers or genetic mutational burden, like methylated cell-free DNAs, metabolic tumor volumes, the tumor mutational profile, and downstaging these tumors prior to transplant also is another area of interest that is going to gain more tractions. And I think the new and interesting area would be limited pulmonary disease for some of these malignancies. If that disease is treated, whether they can become transplant candidates. With regards to perihilar cholangiocarcinoma, very similar, profile. If they are not resectable, very poor survival. Even if they are resectable, their 5-year survival is pretty dismal. If they, very few of them are able to get, margin negative disease, and only those patients up to 40 years, 5-year survival is expected. Everyone else has much lower survival. So transplant plays a bigger role. So in selected group of patients, it's actually low volume disease, limited only to the hilum, no intro or extrahepatic metastasis. Liver transplant is being considered, and very extensive excluding criteria at this point. This is a general protocol that is utilized for these patients. But if you look at the survival, as you're learning more and more about it, the survival is pretty substantial with liver transplantation, with 5-year survival reaching up to upwards of 70% in these patients, and fairly competitive survival to a lot of other malignancies such as HCC and transplantation. So some of these topics of interest in this group that were discussed is the difference between tumor biology versus tumor size. A lot of these indications currently focus on radiologic profile of tumors, but I think as we are learning more about it, tumor biology is going to play a bigger role. Their longer wait times, responsiveness to treatments, their metabolic profile is going to play a bigger role. Another topic of interest that is being discussed is post-neoadjuvant treatment. How long do we have to wait to establish tumor biology? So the argument in favor and at this time is balanced between early transplant after completion versus waiting for additional 6 months to 1 year transplantation. Intrahepatic cholangiocarcinoma, another area of great interest in transplant oncology at this time. A lot of these patients are unresectable because by the time they get diagnosed, they have very large tumors, they have multiple tumors, or tumor location makes it unresectable, or they have underlying liver disease that makes it unresectable. So this is a general workflow for patients who had intrahepatic cholangiocarcinoma. So if they have extrahepatic disease, unfortunately, only treatment option is systemic disease, systemic treatments. If they don't have cirrhosis and they have limited liver disease, a transplant can be considered after an extensive neoadjuvant pathway. If they are cirrhotics and have a smaller tumors, transplant can be considered in those patients. This is one of the studies from Houston Methodist where they looked at patients with locally advanced intrahepatic cholangiocarcinoma, extensive local regional treatment, and up to 6 months to 1 year wait time. And if the disease remains stable, they were able to produce very good results up to 57% 5-year survival. So this is our current protocol that most centers are using based off these studies. Is they have to have intrahepatic cholangiocarcinoma, limited liver disease, no contraindication for transplant, and at this point they don't get any exception points. And now it's goes to those living donors preferred for those reasons. This is a treatment protocol that was used. They get systemic therapy followed by radiotherapy, 6 months to 1 year wait time, and then they get evaluated for transplantation. So future directions in this field are going to be expanding indications for multifocal disease outside of single large tumors, and use of more diffuse systemic treatments such as hepatic artery infusion pump in a peri-transplant period. Now, with regards to expanding donor pool, so there are a lot of interest in new technologies in donor recovery and organ management. Some of those are perfusion devices. These are ex situ perfusion of the liver. This is when the liver comes out, and while it is out of the body, it is being perfused. It allows us to evaluate the quality of the liver and some of the markers that can indicate post-transplant outcomes. NRP is or normothermic regional perfusion. This is an in situ perfusion where the donor DCD donors, while they're being procured, part of their body or the organs are being utilized, they're perfused in the body, or they are reanimated essentially. And then living donation, obviously, that continues to play a bigger role. With regards to normothermic machine perfusion, it has been there for quite some time now. There are several randomized trials that have shown its safety, efficacy, and utility, feasibility in transplant. What already is well established is that it is safe. It reduces early allograft dysfunction post-transplant. The areas that need to be studied is whether improvability complications or the cost are worthwhile pursuing this technology. So as you can see, there has been an increasing utilization of NMP as the time passes, with majority of the livers currently being utilize some form of machine perfusion prior to transplantation. The blue graphs are static cold storage, where the liver is kept on ice in a standard fashion. Red ones are where the pump was used. So what this pump is doing is it increasing substantially some of the peri-transplant outcomes. So if you look at the figure on the left, it is time from waitlist to liver transplant. With the application of normothermic, or as the technology is being widely adopted, the time from waitlist to liver transplantation has substantially reduced. Same is the total days from evaluation to transplant. So the green bars show that the evaluation to wait list, that remain essentially the same. But if you look at wait list to transplant, that has substantially reduced with the application of machine perfusion. This shows that here that how long does it take for you to get transplanted once you go on a wait list, or it's a different metrics of looking at the similar outcome. As you can see that prior to NMP, the number of organs transplanted per 100 listed patient years is 99, and since the application of machine perfusion, is substantially improved to 217. This shows that waitlist mortality has gone down, and the patient survival, 1 year patient survival is improved. Overall survival remains similar for very limited data that we have. And this graph here shows us that why this change happened. And I think the primary reason that there is an increasing utilization of a higher risk organ machine perfusion. So this graph on the right side shows the donor risk index, which is the riskier graphs are being more often utilized than they were used prior to machine perfusion. This is a cartoon diagram of normothermic regional perfusion, which is when a DCD donor passes, their organs are essentially reanimated in their body using like an ECMO type circuit. They get oxygenated blood back into their body, and then organs are at that time, assessed, and their function is essentially enhanced. So the ischemia time and what organ exposes is much smaller. So multi-center study coming from UC San Diego, they looked at different kind of outcomes using NRP. So these are clinical outcomes. There is a very clear advantage of using NRP for livers. It improves, substantially reduces some of the graft-threatening outcomes, as ischemic cholangiopathy, and reduces overall biliary complications. And it also leads to increased utilization of organs per donor. So by application of NRP, there is an increased utilization of organs per donor. So the cost offsets itself by procuring more organs. So the new direction for US would be the HOPE, which is a cold perfusion devices, which are much cheaper and more easily applicable. There's good data from Europe. The data in US is emerging. Currently it is under FDA approval, so hopefully we can get it out and start utilizing. Another topic of interest this year is robotic or minimally invasive surgery in liver transplantation. So so minimally invasive live donor hepatectomy has been there for quite some time. This is the data that compares minimally invasive live donor hepatectomy compared to open. As you can see that there is a open is the red bars and the MISR or minimally invasive are the blue bars. As you can see, the peri-operative complications are substantially lower in the minimally invasive donor hepatectomy. And this is for minimally invasive hepatectomy for donor who are obese, greater than 30 BMI, and very substantial risk reduction. Now the new area of interest would are increasing comfortable or increasing learning curve with robotic surgery is utilization in liver transplantation. So this is an experience with liver transplantation. As you can see that by doing fully robotic liver transplantation, which are essentially much smaller incisions, you can have better hospital ICU length of stay, reduce pain, and reduce patient morbidity. So I think this is going to become a mainstream of liver transplantation in